All right, case 2. This is a guy with hepatocellular carcinoma and tumor in vein. And so as you can see here, you have a contrast-enhanced CT, very heterogeneous tumor in the kind of posterior sector of the right hepatic lobe. And you can see the expansile tumor, the kind of right posterior portal vein pedicle. Here's the angiogram, and you can see on the angiogram the threads and streaks, the kind of classic angiographic appearance of tumor vascular invasion. For these cases, I always start off with a traditional cone beam CT with an end-hole catheter. That's what I did. And if you look at the data from Dosimetry, which is the randomized controlled trial looking at patients essentially like this, huge tumors, tumor in vein, and they were randomized to personalized dosimetry versus conventional dosimetry, and they show this huge survival benefit. They only included patients with tumor in vein who had adequate uptake inside the tumor vascular component. So if you didn't have any uptake in the tumor vascular component, you were not put on the trial. And so we did our first cone beam CT. Here you can see that on the left, the end hole catheter. And there's some arteries going to the tumor, but you really don't see that dense enhancement that you would kind of hope to see for the tumor if you were really going to get a significant amount of radioembolic into the material. So at that moment, we swapped it out for a microvalve. And so here you can see we ended up using the larger size because, as you can see, the artery is quite large. And we repeated the cone beam CT 5-10 minutes later with the exact same parameters, and now you can see a marked difference in the tumor vascular uptake. And so I've really found it pretty helpful for these tumor where there's the threads and wisp arteries where you really need to get more dose into. I found that pressure-directed embolotherapy really helps with these cases.
So basically you started out your mapping, and this is your standard practice, you start out with an in-hole catheter, and if it's, or there's some cases when you know that you're going to go straight to microvalve?
For my mapping procedures, I always start with an end-hole catheter. It helps you get the lay of the land. Sometimes you don't know if there's variant anatomy, and I like to figure things out first. And I just know I'm going to have more flexibility if I do need to go into a weird artery in order to get into it, yeah.
Okay. What are you mapping with, out of curiosity? What catheter?
2.4 Prograde is my kind of workhorse catheter.
Whenever you decide to go from in-hole to microvalve, are you using like a long exchange wire, or do you just get back into it, or just depends on the vessel that you're in?
It also depends on the fellow I'm working with. No, I generally just take the whole catheter out and put it back in. Again,
right.
for this tumor here, it was just a proximal right hepatic run.
Sure.
So it's pretty easy to get back into.
Okay, gotcha. Okay, got it. All right, let's see the next one.
And so as you can see here on the 1 month follow-up, you can see the initial angiogram with the really dense tumor vascular enhancement. And you can see at 1 month follow-up, now you see the kind of expected bland thrombosis with no longer arterial enhancement inside the tumor, conferring that we got an adequate dose into the portal vein invasion component.
What did you treat here with resin again?
We used glass on this case. I'm 50-50 in my practice.
Okay. And ballpark, do you remember what dose you delivered?
So in general, we try and follow Dosimetry. So it's personalized dosimetry, at least 250 grade of the tumor or greater.